Alright, so every industry needs to be funded and everyone within that industry needs to be paid. Traditionally, what companies do is sell goods and services and use that revenue or a part of that revenue to reimburse their employees in the form of salaries. The MedTech industry achieves these same outcomes, but owing to their immense complexities, they do it with different mechanisms. Hey friends, I'm Yash and today we are talking about reimbursements. Now, reimbursements can be classified as payment mechanisms, which, due to the breadth of the industry, are not standardized and vary from country to country. Reimbursements are usually dependent on payers and something which can informally be called payer communities. For the healthcare industry, payer communities include payers not only comprising of patients who happen to derive direct value from healthcare, but other groups affiliated with patients, including insurance and patient advocacy groups. Regardless of which reimbursement methods are used, the industry has implemented these mechanisms with varying degrees of effectiveness. In general, what these reimbursement methods look at are the quality of care, the complexity of care, or the quantity of care. Two of the most popular reimbursement mechanisms for healthcare include FFS or fee for service or payment for performance or value-based healthcare models for reimbursement. Both of these will be discussed in the first section of the video before I move on to talk about digital health and EMR systems. To end, in section 3, I'll talk about reimbursement considering the patient voice and perspective. Having said that, let's move on to section 1 of the video, reimbursement models based on the quantity or quality of care. So, as I said in the introduction of the video, there are really two main ways to reimburse a MedTech or healthcare service. Either you reimburse them on the basis and merit of quality or on the basis or merit of quantity. Some of the most well-known health services, including that of the British NHS, use a version of fee-for-service reimbursement called capitation systems. Capitation systems are a payment mechanism within which physicians or general healthcare providers are paid a predetermined amount for the delivery of healthcare services. Capitation systems, such as that used by the NHS, basically assert a fixed rate at which physicians or healthcare providers need to see, treat, or examine a patient. What this does and ultimately leads to is under-treatment, over-referral of complex patients, and the general reduced quality of healthcare. Now, the more ideal reimbursement model would be that of pay-for-performance or value-based reimbursement models. As suggested by its name, this reimbursement mechanism provides incentives based on the quality of care provided or the performance of the healthcare provider. In short, what pay-for-performance schemes intend to do is link reimbursements to the extent of care provided. Now, to effectively do so, the reimbursement body, usually governments, would have to decide the metrics they would use to judge the quality or standards of care provided. This is indeed a very long struggle, best epitomized by the United States and its decade-long effort to introduce legislation promoting value-based reimbursement models. Out of all the laws you see on the screen right now, the Affordable Care Act or Obamacare, HVBP, and MACRA were some of the more notable legislations. But in reality, what do these payment methods entail? And what are they actually based on? This question is best answered by a 2015 paper, which claims pay-for-performance schemes require well-designed patient identification, classification, recording, and monitoring systems. If we were to actually think about it, any reimbursement model in the healthcare space would require effective patient identification, classification, recording, and monitoring systems. Pay-for-performance schemes would not be the only reimbursement mechanisms using such information, and neither would it be the exception. This thought is best noted in John R. Brighton's 2015 paper, in which he claims the challenge of designing a reimbursement system lies not only in the identification of an appropriate mechanism, but also in effectively obtaining, processing, and utilizing the information required to ensure its optimal functioning. Moreover, he goes on to say, any reimbursement mechanism for healthcare should account for the quality, complexity, and quantity of care delivered. Swiftly moving on to the second section of the video, which will talk about reimbursements in the digital health space and the use of electronic medical records or EMR systems. I'll first tackle the aspect of access to digital health before returning to John R. Brighton's paper to talk about EMR systems. When it comes to the pros of digitalization, if anything, it is seen that products, services, and tasks are done better and more effectively in a digital setting. For example, digital or remote healthcare management could help in a recovery journey while using data it generates to improve care, shorten the duration of care, and improve the overall quality of care delivered. As I alluded to earlier in the video, it's absolutely essential that any healthcare system is reimbursed on the merit of quality. What we don't realize is that reimbursements on the sole merit of quality require clinical outcomes. That is evidence of real value and a measure of positive health outcomes. As the world moves towards remote healthcare management and into the digital healthcare space, we must not forget the possibility that digital health solutions may not yield clinical outcomes in the traditional sense. You see, the difficulties are threefold. Number one, reimbursement frameworks for remote or digital healthcare have standards as high as that of traditional healthcare settings. Both systems yield noticeably different outcomes, and it's simply not fair to hold them to the same standards. Number two, digital and remote healthcare are prone to changing parameters in technology and the settings within which value is being derived from said technology. This is a challenge traditional healthcare systems will not face at a large scale. What these changing parameters actually do is change the value derived from digital health, hence amplifying or reducing the need for reimbursements. And finally, number three, development of technologies and products in the healthcare space happen at a greater scale and pace in a digital setting as opposed to traditional healthcare environments. As a simple example, in traditional healthcare environments, I would need to conduct several clinical trials and whatnot. In the time it would take me to conduct one clinical trial, I could possibly test 10 iterations of a digital framework. Having said that, it's also important to note that every time a technology is used, it changes. Firms in the digital space looking for reimbursements should constantly ask themselves what they are evaluating, or at least which version of their technology they choose to evaluate. Now, coming back to Brighton's paper and EMR systems. A major part of digital health and actually reimbursing these services on the merit of quality requires the efficient storage of patient data, a digital record of healthcare which can eventually be used to determine value of said care. In traditional healthcare systems, EMRs are only used to store patient data, as Brighton appropriately requests. Rather than simply using EMR systems for documentation, it must be utilized to accumulate, synthesize and analyze data and detect patterns and variances that may impact both reimbursements and improvement to care. Having said that, it's time to come to the third section of the video, because when we speak of digital health and reimbursement in the sector, one must also consider the patient voice and perspective. Notably, there should be an investment from the healthcare industry for high-tech medical devices, including MRIs or CT scans. Without such investments, there is no point actually growing access to care, rendering any discussion about reimbursements invalid. To listen to the patient voice, the industry must listen to and balance two key sectors. Number one, patient advocacy groups, and number two, large corporates. For starters, patient and patient representatives barely know anything about reimbursements. Moreover, in reality, patient groups have not matured enough to feel comfortable talking about medical technologies. The MedTech industry, in turn, has not invested enough to listen to the patient voice, hence stranding any patient group's capacity to influence decisions that impact their own health. More importantly, from an industry point of view, there is a lack of transparency when it comes to large corporates and the kind of rebates or discounts they are willing to offer. What this leads to is potentially inflated pricing. On one hand, patient advocacy groups feel that increasing transparency would force large corporates to reduce pricing, while on the other hand, large corporates use their diversified product lines to increase prices and their bottom line. So that was my understanding of reimbursements within the healthcare industry. An industry where quality should take precedent over quantity, where the application of electronic medical records extend beyond simple storage, and where patient and patient groups feel empowered enough to comment on medical technologies and healthcare decision making. If you enjoyed this video and now know about reimbursements in the healthcare industry, you will enjoy this video over here, which talks about how we can build a humanized healthcare system. Anyway, thank you so much for watching. Consider subscribing if you have not already, and I'll hopefully see you in the next video.